Hey everyone, today we're going to be talking about acute periodontal conditions. These are things that come in maybe as an emergency basis and how we deal with them. Stay tuned. Hey everyone, welcome back to the Grow RDH channel. Today we are going to be covering periodontal conditions that are acute. So first we're going to define what an acute condition is. Acute conditions are conditions that have rapid onset. They typically come on very fast, they're emergency based, and typically they're associated with painful situations. Now this is in the vein of perio, so we're going to be specifically talking about periodontal emergencies. And sometimes this can include a periodontal abscess. So we're also going to be covering what periodontal abscesses are and how we deal with them. An abscess is important to address. Typically, it is a circumscribed or localized area of infection that is confined to one specific area. A lot of times, this can involve the accumulation of pus, which is essentially just a collection of dead or dying immune factors like neutrophils, bacteria, fluid, and any debris that's in the area. Suppuration is the process of how that pus forms, and it's important for us to be able to identify if this is happening with our patients and be able to assess and decide where the infection or the pus is coming from. There's two main different types of abscesses, and those two main different types are periodontal or pulpal. There's a couple of different ways that we can use to identify what type of abscess we're dealing with. For periodontal abscesses, it's important to test the vitality of the tooth. If the tooth is still vital and still reacting normally, this should be your number one sign that the nerve is not infected. It's not pulpal, but it's periodontal. Typically on the radiograph, we are going to see bone loss that is not at the apex. You can see here in this picture that the bone loss really is around the furca. And so this should be another sign that the abscess is coming from the periodontium. This type of abscess causes the patients to kind of be in this constant state of pain. It is not intermittent. It usually is always present versus a pulpal abscess. Pulpal abscesses act a little bit differently. When we do a vitality test on a tooth with a pulpal abscess, typically it's going to react abnormally. It could be super oversensitive or it could be completely dead and have no pulp vitality present. On the radiograph, the bone loss is going to be around the apex because that's where the abscess is coming out. It's coming out where that pulp ends at the very tip of the apex. And a lot of the times the pain that patients describe when dealing with a pulpal abscess is kind of like a throbbing or a dull ache that typically comes and goes. We call that intermittent. It's not constant pain. It kind of comes and goes. So if we decide we are dealing with a periodontal abscess, these are some things you should know. Like I said, it is typically circumscribed or confined to an area, and that's a good thing, but that is what the pain is coming from. If it doesn't have a place to drain, it's just going to be building up pressure and causing a lot of discomfort. Typically, the bacteria involved in these type of infections are gram-negative and anaerobic. Those are typically more pathogenic than our gram-positives or aerobic bacteria. It's usually painful. Sometimes it does include a fistula. And a lot of the times these patients experience a fever or an elevated body temperature. These can be caused by a number of different things. A lot of the times there's a periodontal infection and something is blocking the drainage. So there is no place for that infection or that suppuration to come out. It can also be caused by a foreign object. I've clinically, in my experience, seen it be something as simple as like a popcorn kernel or a popcorn hole, something foreign that isn't supposed to be there and the body's reacting. It can also be caused from incomplete calc removal. We've talked about doing a periodontal debridement or a full mouth debridement. This is an example of what can happen if you do incomplete calc removal and the area at the top of the pocket is really healthy and it tries to heal itself back onto the root surface, but underneath there is incomplete calc removal or burnished calc or just calc left behind from the instrumentation. If this happens, again, it's very painful. The patient does not like it. It's a secondary infection to the initial periodontitis infection, and it just causes a lot of discomfort. There's three different types of periodontal infections that we typically see. The first is higher in the periodontium. It's localized to the gingiva. So this could be interdental papilla. It could be along the gingival margin, just anywhere that is in those higher tissues, the higher areas. It can also be in the deeper tissues, right? So we can have a periodontal abscess if it's down deeper in the pocket. And this most commonly affects an area that already had a pre-existing pocket. And like I said, it maybe was treated ineffectively and it has now created a secondary abscess. The third one is when the operculum around a partially erupted tooth gets infected. There is a specific bacteria that typically is associated with this type of infection. We call it pericoronitis, and that bacteria is Strep milleri. A lot of the times these infections come because that tooth is partially erupted. It creates a pocket all on its own. That operculum is the tissue that's kind of partially covering that tooth. And as you can see in the picture, it's very difficult for patients to clean around this. And honestly, it's difficult for us to clean around this. So having that extra tissue, that operculum, can make it very difficult to treat. In these cases, most dentists just surgically remove the operculum to make it easier for the patient to clean and prevent any trismus or any pain associated with chewing on the operculum. So how do we treat a periodontal abscess? Typically, the first thing we want to do is create a path for drainage. If there is a lot of pus, especially, the most discomfort is coming from all that pressure that's been built up. And so if we can create a path of drainage, that's going to take the patient out of pain. And the ways we do this is by puncturing the soft tissue wall of that abscess. You can do this with a Gracie instrument or any scaler that is going to work well. Essentially, you're just puncturing that abscess, making sure that the pus is draining out. Another option is periodontal surgery. If it's very advanced or extensive, this can be done in a specialist office. And we always want to recommend that the patient rinse with warm salt water while the pus is draining, because that helps it drain out and it takes, again, the patient out of, and it just helps with the discomfort. It helps the tissues heal. Once we've taken the patient out of pain, we can now debride the area. Especially if it's being caused by incomplete calc removal, we want to make sure that we instrument and debride the area to make sure it's completely clean. Like I said, if it's a foreign object, right, we remove the popcorn hole. We just want to create an environment where the gum can heal. Irrigation is another really good part of this, especially if it's pericoronitis. We want to irrigate under the operculum, but this applies with a normal periodontal abscess as well. We want to irrigate, making sure we're getting all the pus out there, getting all the pus out of there, and again, creating an environment for healing. All of these things are going to be just helping the patient get out of pain, and that's our main concern: relief of pain and removal of the infection. Next, we're going to talk about necrotizing diseases of the periodontium. Necrotizing in itself means the death of cells or the death of the tissue. Specifically in our case, it is the death of the gingival epithelium. Necrotizing, there are a couple different unique factors that put the patient at a greater risk for being susceptible to necrotizing diseases. A lot of the times it's associated with conditions that put us in immunosuppression, and those conditions can range, right? So specifically it's stress, lack of nutrition, maybe having a poor diet. And it's interesting because the typical age this happens is in that 20 to 30 age. And if you think about that age group and you think about what life changes that age group is going through, they might be going to college, they might be transitioning to life on their own, they might be moving out of their parents' house. And so a lot of the times that could coincide with a lack of sleep, a lack of good, healthy nutrition. Maybe they're living on ramen and energy drinks because they're studying for exams. So any unique and rapid change that can affect their immune system or put them in a state of immunosuppression can greatly impact this and put them at great risk for necrotizing periodontal diseases. There are a couple different bacteria that are specifically associated with these kind of acute conditions. These bacteria are T. denticola, F. nucleatum, P. gingivalis, T. forsythia, and A. actinomycetum comitans. If you recognize some of those names, those are some pretty pathogenic bacteria, and they're a lot of the times associated with severe periodontitis. In fact, 3 of those are the red complex bacteria that are associated with more severe forms. It's important for us to identify this right away, but to be honest, the patient is going to be coming in on an emergency basis, and usually this doesn't typically end up in our chair for that initial visit. That's because they're in so much pain and they're there on an emergency basis. You're not going to be seeing this patient for coming in for their routine 6-month cleaning, and you're going to be like, oh, hey, by the way, you have NUG. They're going to know that they have necrotizing periodontal disease because it is so painful. But it's still important for us to identify the clinical signs and separate this from other periodontal diseases. Some of those clinical signs include having punched out papilla. They've lost their interdental papilla and it typically looks cratered. Another really indicative sign of NUG is having a pseudomembrane. The pseudomembrane is essentially the dying skin cells, right? The dying epithelium. And it creates a pseudomembrane that we can actually remove. And we'll get to that in the treatment section. A lot of the times, obviously, as I said, they are in pain, but also there is a very strong smell to this. They used to call this disease trench mouth, and that's because the smell is so strong. And it's because that the gingival epithelium is dying, and that does create an odor. So let's talk about the treatment. Like I said, the first appointment is going to be that emergency visit when they're coming in complaining of pain. Because of the severe amount of pain, the treatment of this takes time and it takes phases to make sure that we're able to treat it completely and appropriately. So the first visit is typically centered around pain management. In the first visit, we want to remove the pseudomembrane as well. So if we're going to be removing that pseudomembrane, we have to make sure that we take them out of the pain locally. So a lot of the times this would include local anesthetics, but also getting them on a liquid lidocaine or viscous lidocaine. I know a lot of dentists call this magic mouth rinse, and it's a prescription-based mouth rinse that has lidocaine in it. This allows them to take the patient out of pain and be able to actually eat and drink and maybe even brush their teeth without having it just be completely miserable. And so, like I said too, we want to remove the pseudomembrane. Then we want to get them on the mouthwash and send them on their way. We will see them back for the second appointment in 2 days. And again, this is just for pain management. At that 2-day appointment, we are going to do supragingival scaling and cleaning. We can also start subgingival instrumentation depending on how well their pain is being managed. If we are able to get as deep as we can sure do that, but it is unlikely. And again, we're just removing as much of the pseudomembrane and inflammation causing plaque or whatever it is that we can. The third appointment should come about 5 days after that initial appointment. And this is where you're going to complete the instrumentation. They should be managed pretty well in terms of pain. And we want to complete the subgingival instrumentation and cleaning to make sure that we've removed all of those local risk factors like plaque and calc. Once the complete instrumentation is clean, we want to see them back for a comprehensive periodontal evaluation. We want to do this after they've healed. Now, if they're in a situation where they're having a necrotizing disease, that means they're in immunosuppression anyway. So this timeline is a little bit vague. I wouldn't go earlier than 2 weeks. And what we know is that our gingiva and our oral tissues typically heal within 14 days. Now, if they need a little additional time, maybe go 14 days after the complete cleaning, because that will allow them time for those gingival tissues to heal. The purpose of this is that you want to be able to assess their periodontal situation when everything is all healed up to really understand where they're at in general with their periodontal health and kind of determine how this started or what happened and get them on a routine cleaning schedule or a routine situation with you to make sure that this doesn't happen again. Nutritional counseling, oral self-care, all of these things will come into play as well. But I will just say that when they're coming in on that emergency basis and they're in so much pain, you're going to have to fit that in where you find it most appropriate. Necrotizing diseases can show up in both the gingiva and in deeper structures. So the way we define or diagnose this is based on where it's infected. Necrotizing gingivitis is just the necrosis of the soft tissue. So again, very similar to all of the other diseases we've described, is that necrosis is localized. It's only in the soft tissues and it is reversible. When we see these cases, we can typically handle them in office, but we want to make sure that we're referring to a healthcare provider because something in their immune system is off, right? And while it may be related to just their nutrition, just stress, something like that, we want to rule out anything bigger that's going on. So it is important to always refer to a healthcare provider because this can be a sign that something in their overall systemic health may be at fault. But necrotizing diseases can go deeper into the structures as well. And in that case, we would call it necrotizing periodontitis. This is the necrosis of obviously the soft tissue, but also the bone. Necrotized bone is called sequestrum, and it is very severe. In these cases, we need to refer to a periodontist because they are better able to treat this really severe infection. So referring to a periodontist is important, but also you still want to refer them to a healthcare provider so that way they can assess the overall systemic health. The final acute condition we're going to talk about is primary herpetic gingivostomatitis. This is also important to talk about because while this is a kind of a systemic disease or a systemic inoculation of the child that is getting inoculated to the herpes simplex virus, it is important for us to be aware of this because of the oral manifestations of this. Oral manifestations of the initial inoculation of herpes simplex are very rare. We don't typically see it, but it could be present in anywhere from 13 to 30% of initial inoculations. This means that when that child from birth all the way up to 6 years of age is inoculated for the first time with herpes simplex, 13 to 30% of those cases have an outbreak. And that outbreak we call primary herpetic gingivostomatitis. That outbreak has some very severe oral manifestations. And so typically, if the parent sees the manifestations, they're going to go to a dentist instead of a doctor because it is so heavily affecting the oral cavity. The clinical signs here are very similar to necrotizing diseases in that it's extremely painful. These children are at a really great risk for dehydration because it even hurts to drink. So severe pain is something we're going to have to be managing right away. And unlike with adults, kids are a little harder because they may have a limited understanding of what's going on, a limited understanding of how important it is to stay hydrated. All they know is that their poor little mouth hurts and they don't want to drink or eat anything because of the pain. Clinically, it can show up as ulcers or blisters, things that look very similar to cold sores. They can have aphthous ulcers. A lot of the times they present with a fever and swollen lymph nodes because this is a systemic inoculation, a systemic disease. It is so dangerous because of the risk of dehydration, and so we have to treat these very carefully and really work well with the parents. So possible treatments include some medications here. There is evidence that giving antivirals early can reduce the length of the inoculation. An antiviral can kind of slow it down. An antipyretic can really help with the fever, and we're going to end here with analgesics. Very similar to necrotizing, we have to take this child out of pain. So if they're old enough, it's tricky. This typically happens from birth to 6 years old. So maybe probably 5 and for sure 6-year-old can likely rinse and spit. It's hard though to get a toddler to rinse with magic mouth rinse, right? We talked about the lidocaine, the viscous lidocaine. So this is highly dependent on the child's ability to do these things. A lot of the times parents can just kind of default to using like an Oragel, and Oragel is available over the counter and they can kind of use it as needed on the child because it's a gel and they don't have to worry about them swallowing a bunch of it. They're just using it carefully and locally to take them out of pain. The reason we want to take them out of pain is because we have to push fluids. Because they're at risk for dehydration, we just want to make sure that the child can eat and drink. Typically, if they're drinking, that's really, really good, but also even getting the nutrients and staying healthy. In my clinical experience, I've seen a lot of the times that dentists will recommend supplement drinks. So something like Ensure or Pediasure, because they don't want to eat, we want to make sure that they're keeping those nutrients really high, staying healthy. And again, that will help them fight off infections. And those are all the acute conditions that we're going to cover today. If you have any questions, please put them down in the comments. If you're valuing this content, please like, share, subscribe, and I will see you on the next one.